I did 2 fellowships, and my second one was in movement disorder surgery. So I do operations for epilepsy and a variety of movement disorders such as Parkinson's disease, dystonia, essential tremor. And a lot of these operations are either implanting a device into the brain, like a deep brain stimulating device, or sometimes with epilepsy actually removing some abnormal tissue in the brain that might be causing the seizures. It's more common than we think. If we lump together all the folks that have epilepsy, Parkinson's disease, essential tremor, dystonia, it's a significant population, and not everyone's disease is severe enough to justify an operation on the brain, but there certainly is a significant number of folks that are not well controlled with their medications alone and should consider surgery as an option. Unfortunately, it's not a cure. With Parkinson's in particular, what we're able to do with deep brain stimulation surgery is provide a therapy that's constant and continuous. And that's a huge advantage for a lot of folks with advanced Parkinson's, where their daily routine is to take meds. It takes a while for the meds to kick in. Then they may have a brief hour or 2 or 3 where things are pretty good. They may have some side effects during that time. Then the meds wear off, and then they take their meds again, and the cycle kind of repeats all day long. With deep brain stimulation surgery, we're able to provide that benefit. It's not actually much better than the meds in the degree to which they improve, but it's a continuous therapy, so it's on all day, all night. So they don't have these motor fluctuations. And also some of the side effects from the meds can be avoided because in some cases we can reduce meds by about 50%. So patients need less medication, they're experiencing less fluctuations, and it really is a surgery that improves quality of life. It doesn't necessarily stop the disease, but it's able to control and mask a lot of the symptoms. We've been doing deep brain stimulation for a few decades now, and it is lasting for many, many years. It's a difficult question to answer because there are some parts of Parkinson's disease that respond to this therapy and some that don't. Tremors, for example, respond very well, and so those we seem to be able to control for the duration of DBS. We may have to make adjustments over time, but the benefit, is significant. Some of the tightness and slowness also responds quite well to DBS. Unfortunately, some of the other problems like balance problems, speech problems, swallowing problems, those are more difficult to control both with medications or with DBS. So we do see the disease sometimes progress with regard to those symptoms, but some of the other symptoms in the limbs, the arms and hands and legs can be well controlled for many, many years. The key becomes the decision-making and the screening process for who should undergo the surgery. The surgery does have some risks. Fortunately, they're quite low overall. There's about a small risk of infection that is pretty serious because you'd have to take the device out. And there's a small but could be a significant risk of injury to the brain if it were to happen. Luckily, that's less than 1%, so it's very uncommon. So you're really weighing those risks against the benefits, and the benefits are unique for each patient. For some patients, DBS is going to make a great, benefit for them, and they're going to do quite well with it because of the unique symptoms that they have. If you think of someone in the popular media like Michael J. Fox, for example, and the type of Parkinson's he has is very different than the type that we saw Muhammad Ali go through, and so there's a very, special committee that we have that goes through each candidate for DBS to try to understand, is DBS going to provide benefit, and does that justify the small risks of the surgery? So it really becomes a matter of patient selection and having a kind of a multidisciplinary group that can advise patients on whether DBS is a good idea or not. It's a scary diagnosis for that reason, because a lot of patients, especially younger patients, when they're diagnosed, they see these folks as examples of what may become. So we try to be very proactive early on, and I must admit, as a neurosurgeon, I usually don't see them early on. It's usually the neurologists that do that. But there's a lot of discussion, a lot of advice and referral to counseling if necessary to really empower patients with knowledge about what Parkinson's is, what it isn't, and how every patient's experience with Parkinson's is unique. We have many, many patients that live a very high quality life with Parkinson's because things don't progress as rapidly as they feared it may. And there are certain things, with exercise, for example, that do seem to slow things down. So intervening early and helping patients understand what they can do to try to control the consequences of the disease, and also to modify their lifestyle so they can still have a happy quality of life despite living with symptoms. I think education's key. It catches you by surprise when you're diagnosed with something like this.